Manpreet Kaur. Okay, so we can start, I think, right away. So Dr. Manpreet will be presenting Curious Tale of Microspherophakia.
Good afternoon, everyone. So my topic is the curious tale of microspherophakia. So as you know, microspherophakia is a rare congenital anomaly characterized by abnormal spherical shape of the crystalline lens. There is increased anterior posterior thickness of the lens associated with reduced equatorial diameter. It can be seen in systemic or ocular conditions like Marfan syndrome, Brill-Marchesani syndrome, iridocorneal endothelial syndrome, and Axenfeld-Rieger syndrome. It can be associated with complications secondary to the abnormal shape of the lens, resulting in high myopia, subluxation, or even complete anterior or posterior dislocation, and which can lead to secondary glaucoma, corneolenticular endothelial touch, endothelial cell loss, or endothelial decompensation. So this tale begins when an 8-year-old girl, a child of migrant laborer parents, were brought to the OPD with a history of loss of vision and pain in the left eye associated with watering and redness, allegedly after sustaining some sort of trauma while playing few months back. The parents reported that the child had a decreased vision in both eyes from some time, but they consulted some local doctor elsewhere, but her condition did not improve. On general examination, the child was conscious, well oriented, but irritable. Her examination revealed visual acuity of 5 by finger counting at 5 meters in right eye and PLPR in the left eye. Right eye examination undilated was within normal limits. On the left eye, there was diffuse corneal edema. There was a faint view of the AC which showed a dislocated lens. Pupil was not visible, faintly visible. It was dilated. The pressure was 35 millimeter in the left eye and 20 millimeters in the right eye. B scan of the left eye was normal, and the provisional diagnosis of traumatic dislocation of the lens with secondary glaucoma in the left eye is made. Unfortunately, I don't have the anterior slit line pics of the child. So the treatment was started anti-glaucoma systemic as well as topical, as well as the systemic and topical steroids, but the corneal edema did not resolve, and we decided to take the child for lens aspiration because the pressures were controlled, and post-operatively the edema persisted despite, but the child became comfortable. The otherwise was examined then thoroughly. So this is the outer eye finding. We can see minus 22.5 of myopia and minus 8 cylinder, and the biometric findings, they were within normal limits. The axial length was normal, the K1, K2 were normal, but the myopia was very high, so that suggested there is something wrong with the lens. So we dilated the child, and this is the picture we can see. It shows the presence of a small globular lens with equator visible within the pupillary border, suggestive of microspherophakia. So the detailed systemic examination did not reveal any abnormality which may be linked to any syndrome. So the final diagnosis of isolated microspherophakia with anteriorly dislocated lens with secondary glaucoma and corneal decompensation in the left eye was made, and child was referred since we did not have the eye bank at that time. So discussion, it is a very rare condition where the lens is spherical in shape. So detailed examination of the other eye is always helpful in making the true diagnosis. So in this case, the loss of vision was attributed to the trauma which was wrong. So whenever you have a case of unilateral case, even always examine the other eye. So it is imperative to do a detailed examination of the other eye in cases of unilateral presentation, because it may lead you to open up a Pandora box. You may never know what is there inside. Thank you, sir.
Thank you, doctor. Those who have not loaded their presentation, kindly load so that it is easy to present. So next speaker, we have Dr. Vineet Oswal is there. Okay, Dr. Vineet. He is going to present on managing the spheres of lens. Please come.
Good afternoon, everybody. I'll be presenting a case of an isolated microspherophakia. As we know, microspherophakia is a structural lens deformity leading to reduced equatorial diameters of the lens, elongated zonular fibers, and subsequent changes in the curvature of the anterior lens surface. It can cause lenticular myopia, accommodation deficits, raised intraocular pressures, and lens dislocations, usually inferior. LTBP2 gene is usually implicated, and it may occur in isolated idiopathic or familial cases. More than 50% patients have a high intraocular pressures at presentation, with a prevalence of 1.2 among children in India. The common complications are phakic pupillary block glaucoma, angle closure glaucoma, high lenticular myopia, and corneal lenticular touch, and among the others. Associated conditions are Marfan's, Weil-Marchesani syndrome, hyperlysinemia, congenital rubella, and microspherophakia metaphyseal dysplasia. The case was of a 45-year-old female resident of Aurangabad who came to the OPD with complaints of left-sided acute periorbital pain, which was recurrent and was relieved on medications. The redness of left eye associated with intermittent watering, left eye diminution of vision for far and near since the past 2 months, which was gradual, painless, and progressive. The patient had similar complaints in the right eye 6 years ago, for which she took treatment outside. She had only history of right eye cataract surgery 6 years ago and was using spectacles since then. Currently, she was prescribed tablet acetazolamide 250 mg BD with both eyes eye drop, dorzolamide and timolol combination BD from the private practitioner. The systemic examination was within normal limits. On visual acuity, the right eye visual acuity was 6.9 parts, improving to 6.6 with pinhole, and left eye was finger counting 6 meters, improving to 6.18 parts. On Goldman's applanation tonometry, the IOP on the right eye was 14 and the left eye was 40 mm of Hg. As we see here, the clinical pictures of the both, the right eye, the pupil was normal, anterior segment was normal with the presence of a PCIOL. In the left eye, we had circumciliary congestion with iris pigment dispersion on the endothelium, a von Herrich's grade 2 reaction with flare and irregular AC temporally. There was a 4 to 5 mm non-reactive to light pupil with pupil peaked at 5 o'clock, and there was a presence of IMSC, that is NO2 grading according to LOX 3 criteria, with the edge of the lens visible temporally, and there was iris pigment on the anterior capsule of lens as well. The slit lamp evaluation with a 90D lens was normal for the fundus. On further investigations on ASOCT and pentacam, there was a shallow AC depth of 0.93 micrometers, and the dimension of the spherical lens were 5750 by 4420 micrometer. On gonioscopy, the crowding of the anterior lens structures were seen. The IOP was controlled with 100 cc mannitol BD and with Dimox 250 mg BD and syrup Kesol, eye drop homatropine 1 drop TDS. The inflammation was further controlled with tablet Visolon 30 mg OD with a 3-day tapering. The intraoperative images were seen in which we can see the edge of the lens temporarily present through the dilated pupil and a spherical cataractus lens. She was then posted for a second lens extraction surgery and then posted for a secondary IOL implantation under peribulbar anesthesia. Her post-op vision in the left eye was in the right eye was 6.9 parts, and both eyes were improving to 6.6 parts. She is now on topical anti-glaucoma medication with 3 monthly follow-up for the same. So in our case, the conclusion was of an acute angle closure glaucoma by the pupillary block by the spherical lens, and which caused raised intraocular pressure and irregular AC depth. It was relieved by the anti-glaucoma medication and removal of the spherical cataractus lens. After management of the inflammation and the IOP, secondary IOL placement may be a surgical viable option, and timely removal of the spherical lens is important for the same. Thank you.
Thank you, doctor. The next presentation, we have Dr. Prem Vada. She is going to present on opposite clear corneal incision versus toric IOL to correct the astigmatism post phacoemulsification.
Good afternoon. I am here to present on the topic opposite clear corneal incision versus toric intraocular lens in correcting astigmatism post phacoemulsification. The total refractive astigmatism of the eye is a combination of corneal and lenticular astigmatism with a major part coming from the cornea. In India, we have a high prevalence of pre-existing corneal astigmatism of more than 1 diopter in patients undergoing cataract surgery. In them, the PA can be corrected during the same sitting of cataract surgery by either incision-related procedures or toric intraocular lens implantation. In case of toric IOLs, they are very effective in correcting PEA more than 1 diopter, but they have certain limitations like under or over correction and post-operative IOL rotation. Moreover, they are an expensive option for most of our cataract population. With OCCI, an addition of same size of penetrating opposite clear corneal incision to the first main incision on the steep axis of cornea can enhance this flattening effect and reduce the PEA to the greater extent. It is a simple intervention requiring no added instruments or skills and can be performed in the same sitting as a cataract surgery without any added cost. We did a prospective interventional comparative study from June 2022 to Jan 2023. We selected patients with regular corneal astigmatism of 1 to 3 diopters, and they were divided into two groups. Group A underwent phaco with OCCI, and Group B underwent phacoemulsification with toric IOL implantation. All these patients underwent sutureless 2.8 mm clear corneal phacoemulsification. In the toric IOL group, toric IOL was implanted in the back with the axis of the cylinder aligned along the steep axis marked on the cornea. Whereas in OCCI group, foldable intraocular lens was implanted in the back, and a 2.8 mm self-sealing clear corneal incision was made with a keratome 180 degree opposite to the main incision on the steep meridian after the IOL implantation and before removal of the viscoelastic. We also divided the eyes into three groups with PA ranging from 1 to 3 diopters, and based on the white to white corneal diameter, we divided the eyes into four groups from 10.5 to 12.5 mm. We measured the uncorrected distance visual acuity, manifest refractive cylinder and corneal astigmatism with tomography at preoperatively and at 6 weeks postoperatively. So 60 eyes were analyzed with 30 eyes in each group, and the mean age was 66 in OCCI group and 67 years in toric group. At 6 weeks, 83.3% eyes in the OCCI group and 96.7% eyes in the toric group achieved an uncorrected distance visual acuity of 6/9 or better. There is no statistical significant difference between the groups. In OCCI group, the mean corneal astigmatism reduced significantly from 1.57 to 0.97 diopter at 6 weeks. And in toric group, the mean corneal astigmatism reduced from 1.81 to 1.65 at 6 weeks. The difference in mean corneal astigmatism reduction between the two groups was found to be statistically significant. The residual mean cylindrical refractive error at 6 weeks was 0.6 in the OCCI group and 0.05 in the toric group, and the difference was found to be significant. And the reduction in PEA based on the white to white corneal diameter was more in smaller white to white corneal diameter, proving that incision made close to the visual axis leads to more correction of the PEA. So I conclude that even though both OCCI and toric IOL are effective in correcting pre-existing astigmatism, in case of resource-limited settings like many centers in India, we can try OCCI, which will correct pre-existing astigmatism of 1 to 1.5 diopter during cataract surgery by phacoemulsification without any added surgical skills or any equipments at no added cost.
Yeah.
Thank you.
Thank you. I think this OCCI is effective only for a very small amount of astigmatism. Usually, if the patient has astigmatism within 1 diopter, if the astigmatism is more than 1 diopter, usually OCCI doesn't help. Either you go on for the LRI or you go for a toric lens.
Yes,
so for small amount of astigmatism, where you think you can correct by OCCI, it's okay. So maximum correction along with the main wound and the opposite clear corneal is just about 0.5 diopters. So more than that, it doesn't correct. Thank you. Thank you very much. Next we have a comparative study of complication associated with peribulbar and subtenon anesthesia for SICS. Presenting person is Dr. Sonali Shevan.
Good morning everyone. I'll be presenting comparative study of complications associated with peribulbar and subtenon anesthesia for manual SICS. Cataract surgery is one of the most common surgical procedures with a good safety profile. As cataract surgery has evolved over the years, so has its anesthesia techniques. Shorter acting and less invasive methods are used nowadays. So this study was conducted to compare the efficacy of peribulbar technique with subtenons. The study setting is a tertiary care center. It was an observational study. The estimated sample size was 61 in each group, and the patients admitted for SICS were included. The exclusion criteria was ages less than 30 and more than 90 years, patients with obvious contraindications to anesthesia, allergy to the drug, a history of convulsions, epilepsy, inability to give informed consent, and less dilating pupil. The study was carried out in the Department of Ophthalmology in a tertiary care center after ethical committee approval. The patients admitted for SICS were enrolled and they were divided into two groups, and a detailed history and ophthalmic examination was done. And the data was collected in percentages and the rates of complications were noted. A total of 112 cases were studied to compare the complications, and the present study revealed that the incidence of subconjunctival hemorrhage was 13.1% in the subtenons group and 11.5% in the peribulbar group. The chemosis was 31.1% in peribulbar group as compared to subtenons, which was 8.2%. And retrobulbar hemorrhage was found only in peribulbar group, the percentage being 4.9%. And the other severe complications were not found in any group. So to conclude, the study observed that subtenons anesthesia is associated with lesser complications, less incidences of chemosis, and no incidence of retrobulbar hemorrhage. The incidence of subconjunctival hemorrhage was almost equal in both groups. Ocular movements were more pronounced in subtenons group, whereas pain and discomfort during administration was more with peribulbar group. So therefore, I conclude that subtenons anesthesia might be a good alternative substitute for peribulbar anesthesia. Thank you.
Was there any difference in the amount of the anesthetic used in both the groups?
No, sir.
How
Sir,
much?
the volume
Yes,
of
volume of the anesthetic.
volume of anesthesia in subtenons group, less volume is required. 3 ml is sufficient. 3 to 4 ml we use, sir.
And was
And
it
in peribulbar group, 6 to 7
was
ml.
it given before the surgery or just during the surgery? Subtenons.
Before the surgery, sir, and immediately it was started
Because
after
we need
massaging.
to put a speculum for giving the subtenon.
Yes, sir. We had
anesthesia.
put the speculum and then we had given subtenons. After washing only, we had given subtenons and then we had started the surgery after massage.
Thank you. The next presentation we have by Dr. Ishan Pasricha is there. He is going to talk about firecracker fiasco. How one lady's left eye tried to celebrate Diwali. So be careful about cracker injuries. Doctor is there? He's not there. Oh. Then we have Christmas tree cataract presentation by Dr. Diksha Katoch. Your Diksha? Diksha Kamath, not Katoch. Yeah, sorry. So she is going to talk about Christmas tree cataract.
Good afternoon, everyone. I will be presenting a case of Christmas tree cataract. So, Christmas tree cataract is a rare type of cataract with polychromatic luster described as iridescent needle-shaped refractile lenticular opacities. It is most commonly associated with myotonic dystrophy. So, here's a case of unilateral idiopathic Christmas tree cataract. So, 70-year-old male patient with diminution of vision in both eyes since 1 year, which was insidious in onset and progressive in nature, presented to us with a patient doesn't give any history of glare. There's no history of any ocular trauma, no known comorbidities, or patient was not on any medication. So vision in right eye was 6/36, whereas in left eye was 6/24. Lids and conjunctiva were within normal limits. Cornea was clear in both eyes. Anterior chamber was normal depth and optically clear in both eyes. Pupil was 3 mm round, regular and reactive to light in both eyes, whereas in right eye, lens showed multiple glistening polychromatic needle-shaped lenticular opacities in deep cortex, whereas left eye was senile immature cataract with nuclear sclerosis grade 2 with posterior subcapsular cataract. Intraocular pressure was 14 and 15 mm of Hg in both right eye and left eye. Posterior segment examination was normal. Here we can see that right eye shows multiple polychromatic luster. So management was like patient underwent both eyes phacoemulsification with monofocal foldable IOL implantation under local anesthesia in right eye, followed by left eye with 1 month interval between 2 surgeries. Post-operative vision was satisfactory with right eye 6/9 and left eye 6/9 parts. So Christmas tree cataract is a rare lens change. It shows a spectacular display of multiple colors that glitters with the change of incident light like an illuminated Christmas tree. It has been reported that it can be due to cholesterol crystal deposition or age-related accelerated breakdown of denatured protein induced by increased calcium levels, and also can be because of cystine accumulation causing crystallization. It may be found incidentally in most of the cases since it is visually non-disturbing in most of the cases, but they can progress and impair vision. So this type of cataract is often related to autosomal dominant myotonic dystrophy. Detection of Christmas tree cataract on routine examination should necessitate a neuromuscular assessment in these patients. So it is typically idiopathic but has been detected in nearly 16% of patients with myotonic dystrophy 1. Earlier detection of Christmas tree cataract, which is a common ophthalmological finding in DM1 patients, and referral for neuromuscular assessment could possibly speed up diagnosis of the disease. In this case, patient was planned for cataract surgery along with routine investigation. Systemic workup for myotonic dystrophy was done, like serum creatinine kinase, ECG and 2D echo was found to be normal. However, patient is asked to be in close follow-up. These are my references. Thank you.
doctor. Do these patients need any special care during cataract surgery? Or just like a routine cataract you can do? Capsular excision possible? So next talk we have late intraocular lens opacification after cataract surgery, a case report presenting author Dr. Shwakta Nandini. Dr. Shwakta.
Good afternoon. Today my topic is on late intraocular lens opacification after cataract surgery, a case report. Introduction. Intraocular lens opacification is an uncommon but serious complication of cataract surgery affecting visual acuity and contrast sensitivity. It can cause significant deterioration of visual performance and may necessitate IOL explantation and exchange. Clinical identification and evaluation of this condition is important as a misdiagnosis may prompt surgeons to perform unnecessary interventional procedures such as NDI capsulotomy or vitrectomy, resulting in complications. History of presenting illness. A patient comes with a complaint of diminution of vision in the left eye for the last 6 months, which was gradual in onset and progressive in nature and not associated with any pain, redness, itching, watering, etc. The patient had undergone phacoemulsification surgery for the left eye in April 2012 at MMCH, Guwahati, Assam. Under slit lamp examination, significant opacification of IOL was seen. All general and systemic examination was found to be normal. Preoperative ocular findings on slit lamp examination. On the left eye, the vision was found to be 660. Lids, conjunctiva, cornea were normal. AC was deep and quiet. Iris details clear. On lens examination, we saw PCIOL opacification for the left eye, and there were early cataractous changes in the right eye. And IOP, syringing and fundus were normal. In fundus, we saw the media was hazy due to PCIOL opacification. The IOL was in situ. The disc was average size and rest details were within normal limit. Here's the photo. The blood investigation, serology and ECG reporting was normal. So diagnosis was late onset intraocular lens opacification. The patient, for management, the patient was planned for PCIOL extraction with secondary hydrophobic acryl IOL implantation. For post-op medications, we have given moxifloxacin with dexamethasone, 1 drop 6 times, left eye for 2 weeks, and then 4 times for 4 weeks. And carboxymethyl cellulose was added for 6 times for 6 weeks. Post-op slit lamp finding was, for the left eye, visual acuity reached to 612 partial. The rest were within normal limit. The post-operative finding, the exchanged IOL was immediately preserved in the freezer and sent for ophthalmic devices research and pathological analysis. On examination under microscope, silicon along with some calcium was detected on the removed IOL. Aqueous humor components were measured by automatic biochemical analyzer. Discussion. IOL opacification is a rare complication. In this case, the opacification was concentrated on the entire lens matter. Change in intraocular microenvironment, especially aqueous humor, is an important factor for accelerated calcification. Breakdown of the blood-aqueous barrier is also a factor in IOL opacification. So we reported a late onset hydrophilic acrylic intraocular lens opacification and analyzed the case causes through a series of clinical and laboratory tests. We did IOL explantation and exchanged it with a new secondary hydrophobic acrylic IOL, and the vision has improved eventually. Thank you.
Thank you. Next speaker, we have Dr. Sharad Bhardwaj. A study on prevalence of refractive errors, strabismus and amblyopia in pediatric age group.
Good afternoon, everybody. My topic is to study the prevalence of refractive errors, strabismus and amblyopia in pediatric age group less than 12 years in tertiary care hospital. Introduction. Refractive errors have been reported as the leading cause of visual impairment in school children worldwide. Uncorrected refractive error in the long run can lead to amblyopia and strabismus. It is estimated that about 1.6 million children less than 12 years of age are visually impaired from uncorrected refractive errors in India with a prevalence of 0.6%. A cross-sectional study was done in the OPD of upgraded Department of Ophthalmology, LLRM Meerut, during 1 year of period. Informed consent was obtained from the child's parents and guardian. All patients underwent a complete ophthalmic examination, including a detailed history, UCVA, BCVA, fundus examination by direct and indirect ophthalmoscope, cycloplegic refraction using 1% cyclopentolate. Children less than 12 years with diminished vision and asthenopic symptoms were included in my study, and children with congenital strabismus, children with other pathological causes of defective vision, and chronic medical or mental condition were excluded from my study. During the observed study period, a total of 200 children presented at our ophthalmology OPD. The mean age of the children were attended was 7.5 years. Of the 200 children, refractive errors were present in 128 children, that account 64%, out of which 49.2% were having astigmatism, 28.1% were having hypermetropia, and 22.7% were having myopia. This is the pictorial representation of the same. In this table, we can clearly see that in the age group of 5 to 8 years of age, hypermetropia is more common, whereas in 9 to 12 years of age, myopia is common, plus compound myopic astigmatism and missed astigmatism is common. Strabismus was seen in 3 children, out of which 2 had esotropia, in which 1 had hypermetropia and 1 had compound hypermetropic astigmatism. Amblyopia was found in 6 children, and all of them presented after 7 years of age. In our study, hypermetropia and astigmatism are refractive errors prone for amblyopia and also showed an increased prevalence of these refractive errors. Conclusion. Our study showed that astigmatism was the most common refractive error and commonest association with amblyopia, and hypermetropia was found to be a common association with strabismus too. Amblyopia and strabismus was found in children who presented to us late after 7 years of age. Thank you.
Thank you, doctor. This is a hospital-based study, so the prevalence of astigmatism, refractive error is going to be high, because this is not a population-based study, so this cannot be contrapolated to a population study. So, because the children are going to present to the hospital for their problems only. Okay, thank you. So next we have my friend Dr. Smith. He's been my student at GMCH Medical College. So he's going to talk about clinical results following implantation of an Indian posterior chamber toric phakic IOL. Dr. Smith, please.
Thank you, sir, for the kind introduction. A very good morning, respected chairperson, sir, my dear friends and colleagues. The topic of my presentation is clinical outcomes following implantation of an Indian posterior chamber toric phakic IOL. I declare no financial interests. So phakic IOLs have numerous advantages over keratorefractive surgery or refractive lensectomy for correction of high myopia. The purpose of this study was to evaluate the visual and refractive results and safety of a new Indian posterior chamber toric phakic IOL IPCL V2.0, which has an aspheric optic and has a wide range of spherical powers ranging up to -30 diopters and cylinders up to 15 diopters in 0.5 diopter steps. Astigmatism more than 1 diopters, we implanted toric IPCL after a workup, and so this was the retrospective study, and 193 eyes of 99 patients underwent toric IPCL implantation, and 1 year follow-up was available for 111 eyes. The mean preoperative spherical equivalent was -11.35 diopters, and the cylinder was 1.94 diopters, which reduced to 0.34 diopters post-operatively. Post-operatively at 1 year, the average vault size was 543 microns. Only 6.8% of the patients had a residual cylinder more than 0.75 diopters at 1 year follow-up. And the difference between post-op UDV and pre-op CDVA was 96%. 51.3% of the eyes had a visual acuity of 6/6 or better, and 87.3% of the eyes were seeing 6/9 or better. No eye developed secondary glaucoma, cataract, retinal detachment, or endophthalmitis. Only one eye required IPCL explantation because of high vault, for which exchange was done. This patient in particularly was, in fact, the second of the twin sisters that we operated. The IPCL size was 12.75 for a white to white of 11.4 mm, which gave us a vault of 1550 microns, and on post-operative day 3 it had reduced to 1270 microns, which was still high. So we exchanged it with a smaller IPCL of 12.25 instead of 12.75, and we got a vault of 950 micron, which was still acceptable. And for the left eye, which we operated, we don't operate both eyes on the same day. So left eye we had ordered 12.25, which gave us a resultant vault of 756 microns. So in a comparative study between IPCL and ICL, both the phakic IOLs demonstrated similar efficacy and safety, and the results of this new model of Indian IPCL are very encouraging. Though the search study had certain limitations of a smaller sample size and a shorter follow-up period, notwithstanding, our study demonstrated satisfactory visual and refractive outcomes with toric IPCL v2.0, and IPCL definitely provides a safe, effective, and an economically viable option for surgical treatment of high myopic astigmatism. Thank you so much for your kind attention.
Thank you, Sneh. Just one question.
Yes, sir.
The perioperative parameters which we check for the
Yes, sir.
ICL
Yes, sir.
versus this IPCL, or same, or there is any difference
It's
between
same, sir. In fact, here we have gone up to even 2.7 ACD. It works pretty well.
2.7?
Yes, yes.
So you can take little more risk.
Yes, sir, yes.
And any chances of glaucoma with this lens?
So far, we have not seen any.
Early post-rise of pressure?
Yes, sir. So what we do, we immediately after surgery, we don't discharge. We keep the patient in IPD for about 2 hours. We check the IOP after 2 hours, and then once again after 4 hours, and then we discharge. Also, since we don't operate both the eyes on the same day, so that still gives an added margin of safety for the other eye. Like in this particular patient who had a high vault, if we had implanted both the IOLs on the same day, we would have to exchange both.
And any difference in the long-term complications?
So far we have followed.
Long-term, I mean like cataract and other.
So it's too early. We don't have sufficient data to say.
Thank you.
Thank
Nice
you, sir.
presentation. Next we have opaque IOL or a tertiary cataract case report of a rare but vision interfering complications. Dr. Rupa Kala is there?
Good afternoon, everybody. A tertiary cataract. This is a case report which is rare but vision interfering. Opacification of intraocular lenses, though rare, have been reported. As we saw, my other colleague just talked about this. Here also we are reporting a similar condition, but this is a sulcus fixated opaque foldable intraocular lens presenting as a pearly white tertiary cataract within 6 months of cataract surgery with an adult with no comorbidities. A 48-year-old male presented to us with a gradual, painless, progressive diminution of vision in the right eye since 18 months. He had undergone cataract surgery about 2 years back with no records available. His vision did improve after cataract surgery, but within 6 months, he started finding reducing vision and with whitish discoloration. The vision was PL with accurate PR in right eye, 6/12 vision in left eye with no pinhole improvement. Slit lamp examination revealed an opaque IOL with probably a hydrophilic in the sulcus, intact PC and SICS scar. He was evaluated for systemic and there was no comorbidities. We performed an SICS and an IOL exchange with rigid PMMA PC IOL and a local anesthesia. Surgery was uneventful and we on post-operative day his vision improved to 6/12. His BCVA was 6/6 with a 0.5 diopter sphere with an addition 2.5 diopters. So intraocular lenses opacification is an uncommon post-operative complication, but though rare can cause, because there are many causes: low quality IOL, vitreous disturbances, not in the bag IOL, disturbed blood aqueous barrier, and also we have to identify this condition especially in non-dilating pupil, because we can confuse this as a PCO and proceed to NDA capsulotomy. So foldable IOL, especially hydrophilic IOLs, may become discolored and pose like cataract, post-cataract surgery, and IOL exchange is a must to rehabilitate vision. Thank you. These are my references.
Any reason why the doctor put this lens in the sulcus, not in the bag?
Sir, the PC was intact.
That is what I want to know. Was the PC intact or
PC was intact. Probably stereopsis.
stereopsis? But
That-
maybe the reason sometime in SICS the capsular axis is quite big, so maybe it just pops out of
pops
the
out.
bag during the post-operative period.
That might also be.
Thank you.
Thank you, sir.
Next we have Dr. Ravi Chandra. He is going to talk about influence of astigmatism on unaided near and intermediate vision in pseudophakic patients.
A very good evening, good afternoon to everybody. So, I think, my presentation is about the influence of astigmatism on unaided near and intermediate vision in pseudophakic patients. So, the questions we asked was, is astigmatism helping in near vision? Are we overcorrecting astigmatism with toric lenses? And exactly how does astigmatism influence our intermediate and near vision without glasses in patients who are pseudophakic? And how much degree and what axis does it cause problems? So, because we all know cataract surgery is the most common surgery that is performed in ophthalmology, and our patients' demands are increasing day and day, and they want spectacle-free, good vision from near, far, intermediate. So the only options right now we have are multifocals. They have dysphotopsias. We have micromonovision. There we have some depth perception problems. So no single surgery gives you, all the benefits. But so we wanted to see that in astigmatism, does it really can give patients spectacle free or spectacle independence vision? So that was the justification for our study, because elderly population mainly have intermediate to near work. They don't have much of distance work. So if we leave a little bit of astigmatism, can we help in their daily routine? So the materials and methods were, we had inclusion criteria was the best corrected visual acuity for distance should be 6/6, right? So that means there should be no visual axis opacification and no macular disorders or no other comorbidities in the eye, no coexisting ocular pathologies, and patients should be more than 18, and we only tested this on monofocal lenses only. No multifocals, no torics, no EDOF, no monofocal lenses put. So this was the chart which we used. It was a logmar chart provided by by Johnson & Johnson. So it had testing for intermediate vision at 66 centimeters and for near vision at 33 centimeters. So eventually the question is all astigmatism good or bad? So what we found was a myopic astigmatism actually did help in near vision and intermediate vision with a minimal compromise in distance vision. So patients eventually reached a 6/9 N6 binocularly, especially, and what degree or what amount of astigmatism up to 0.75 was beneficial in any axis, but beyond -1 it started to deteriorate the distance vision quite significantly, whereas hyperopic astigmatism was bad throughout, even distance and near, whereas mixed astigmatism, as the name gave very mixed results. Sometimes it was good, sometimes it was bad, but it was worse than pure simple myopic astigmatism. So that is the conclusion, that little bit of myopic astigmatism is good for near and intermediate vision for those who cannot really go for toric IOL implantation. So the clinical implication is just try not to overcorrect your astigmatism, and if you a little bit of mild astigmatism may actually prove beneficial to give a spectacle-free vision. Thank you.
Thank you, dear. It helps in depth perception also.
Depth of focus
If you leave
increases.
about small amount of astigmatism, it is always helpful. So the last speaker we have Dr. Anshuman Patnaik. He is going to talk about central corneal thickness changes following 6 mm MSICS using intratunnel phaco-fracture technique. Suraj.
Good afternoon, everyone. I'll be presenting on central corneal thickness changes following 6 mm MSICS using intratunnel phaco-fracture technique. So as we know, SICS and phacoemulsification are the mainstay of cataract management, and cornea is the major refracting surface, and corneal clarity is maintained by the endothelium. Ideal way to measure endothelial function is a specular microscope. However, in absence of a specular microscope, pachymetry can be considered. Cataract surgery causes damage to corneal endothelial cells, for which CCT serves as an indirect measure for corneal endothelial function. Time to recovery depends on surgical technique, type of viscoelastic used, irrigation fluid used, and IOL implanted. Intratunnel phaco-fracture is a new SICS technique to manage all cataract sizes in a 6 mm incision. In this technique, nucleotomy maneuvering takes place in the sclerocorneal tunnel, and the risk posed to corneal endothelium is hence minimized. There was no studies done for this type of cataract surgery, so we did this study. 60 patients were selected for cataract surgery, and the study was done. Preoperative and postoperative analysis was done. This is the surgical technique. 6 mm sclerocorneal incision was done, and after the routine steps of cataract surgery, using a Lewis lens loop, the cataract was engaged in a sclerocorneal tunnel, and then phaco-fracture was attempted. The fragment was extracted, and the remaining fragment was rotated and removed outside. These are the results. CCT was preoperatively 503, POD1 it increased, and gradually it decreased. The mean difference for CCT was 52 microns on POD1, which subsequently decreased to 15.617 and 0.033 in the next POD7 and POD42 readings. IOP was also increased in the POD1, and it gradually decreased. Multiple studies were done for CCT measurement after cataract surgery, which concluded that CCT increased in early post-operative periods, but returned to the near baseline after 1 month of surgery. Another study revealed that POD7 CCT value, when compared with preoperative CCT, was statistically significant. However, in our study, this relationship was found not to be statistically significant. Hence, this may be attributed to the fact that since lens nucleus is broken in a sub 6 mm sclerocorneal incision and removed, the damage to corneal endothelium is reduced. Conclusion: the central corneal thickness was nearly 10.48% above on POD1. Subsequently, it reduced to 3.1% and 0.006% on POD42. IOP also reduced to pre-surgery levels, and hence we can conclude that changes in central corneal thickness following intratunnel phaco-fracture technique are comparable to other methods of cataract extraction. Recommendations would be to use a specular microscope, a larger sample size, and extended follow-up period for a better analysis. Thank you.
Thank you, doctor. Thank you. I think with this we come to the conclusion of this session. So we hand over the mic to the chairperson of the next session. You are?